I'd like to talk about the submucosal endoscopy. I'm Haruhiro Inoue. This is my first space is a GI lumen, and the second space is abdominal and the thoracic cavity. Submucosal space is the third space, and that is the created artificially. Poem opens the door of submucosal endoscopy, and actually we have several application offshoot of poem procedure. Dr. Ernest Heller, he reported the Heller myotomy approximately 100 years ago. Now we can do it using a flexible endoscope. So world first case of a poem that was done in 2008. Please note the date of the procedure, September 8th, 2008. So we place the poem in the anterior wall of the esophagus. So this is the submucosal tunneling. After creating the submucosal working space, now we are trying to cut the circular muscle. This is the completion of the circular muscle myotomy. Then we just close the mucosal entry using clips. This is the volume swallower before and after procedure. We follow this patient 8 years after of the point procedure. Patient satisfaction 100%. He can eat well and then gain weight 20 kilogram last 8 years. The patient actually has no good symptom as no good endoscopic good. So far in our hospital, we performed the more than 2,000 cases of POEM. Indication of the POEM procedure is oral achalasia patient, and the other esophageal motility disorders with our symptom, dysphagia, or sometimes such as pain. This is a case of a diffuse esophageal spasm. So left you can see very well the very typical image of the contrast media swallow. On the right is the right after procedure. The volume can pass through the esophagus very smoothly. So in this case, we are trying to preserve the lower esophageal sphincter muscle. So because the high resolution manometry beforehand procedure, LES has a normal function. What I mean is that when the patient swallowed, the LES was open. open. This is an endoscopic view before myotomy. So you can see a lot of abnormal contractions of the esophageal body. This is a myotomy. It's the very end of the submucosal tunnel. So muscle layer promptly switched to thin muscle layer. So this is the lower esophageal sphincter. So in this case, we are trying to preserve it. So proximal side, all the circular muscle was already dissected. So we place a long myotomy because the patient has a lot of abnormal contractions. Then we place the long myotomy of the esophageal body. Then after that, we close the mucosal entry simply using the clips. This is Eckert score. Before procedure was 9, but after 1 year after perform, the patient has no symptoms. Next, I'd like to talk about the one of the application of a poem procedure. So this is a tumor resection. We reported this procedure as a POET, part or endoscopic tumor resection, under 2012. And the Chinese doctor Shu and Dr. Zhong's Pinhorst group reported at the same time. They reported it to Journal of GIE. So, so POET is a totally same procedure to STAR procedure. So this is a case. You can see a submucosal tumor. The ultrasonography demonstrated this is a submucosal tumor directly connecting to the fourth low echoic layer. So CT scan demonstrates this submucosal tumor located in between the trachea and the descending aorta. So in this case, used to be we perform the trachoscopic resection in such a case, but now we can do it flexible endoscopic resection through the submucosal tunnel. Now we are approaching to the 5 centimeter proximal from the tumor. So now we are approaching to this tumor. This tumor was FNA demonstrated leiomyoma. Anyway, so we mobilize the whole the tumor, and then so this leiomyoma is connecting to the circular muscle, and in some part directly connecting to a longitudinal muscle. So now we are retrieving the tumor through the patient mouth. So this is the right after resection of this tumor. So you can remember the CT scan. Right after tumor resection, we have a big defect of the muscle layer. You can see a trachea directly through the submucosal endoscope. On right side, you can see membranous portion of the trachea, like this. Right after tumor resection, you can see trachea through the big defect of the muscle. This is a membranous portion of the trachea. So even though we close the mucosal entry just using the clips, that's enough. Following day, patient can start leukemia. So one of my colleagues, Dr. Onima, so he reported our results of a POET. So in his analysis, tumor less than 4 centimeters is a good indication. So this is data of a STAR from a large data from Dr. Zhou Pinho's group, and he also has the similar results. A tumor size less than 35 millimeters is a good indication of the STAR procedure. So this is the data from Hong Kong. So Philip Chu reported. So less than 4 centimeter tumor is the best indication of this technique. So unblocked resection rate is 94, and the complete resection 98. That's a good results anyway. Next, I'd like to talk about the application of a gastric poem for gastroparesis. So this is a schematic drawing of the G poem. We create the submucosal tunnel 5 centimeter, 5 or 3 centimeter proximal from the pylorus ring, and then approach to a pylorus muscle. We just dissect the pylorus muscle. It's a regularly 1 centimeter or 2 centimeter length. So world first case of a G poem was done by ourselves. So myself and Dr. Moen Kashyap and Dr. Stavropoulos. So we are together in the Johns Hopkins University, 2013. Then we get the world first case of the gastric poem. So Dr. Moen Kashyap, he reported the G poem experience to the GIE. So he also reported the multi-center trial, the 30 patients cases, and the success rate is 86%. Or this is our patient in Japanese patient. So before G-poem, the junction was tight, and the gastric lumen was filled with the food residue. We have already cleaned it up. And then now we are approaching to the pylorus muscle in the submucosal tunnel. So after dissection, you can see on both sides the cut edge of the pylorus muscle, and then the center you can see a thin muscle layer, that is the duodenal muscle. Right after complete myotomy, we close the mucosal entry using several clips. And like this, G-poem is technically not so difficult, and most of the case, this is a very effective procedure. Next, I'd like to talk about the Tsenka poem, Z poem for Tsenka diagram. So this case please note the top of the image. You can see a deposit of the contrast media to the right side. You can see better. Contrast media stay in the divertigram. So this case is actually a clearangionism, but procedure is the same to Tsenka. So like this, a lateral divertigram. So so you can see a septum in front of us. So in the Z plane, now we directly approach to the septum top. So injection first, and then open the mucosa. The getting a submucosal space, you can see a septum muscle. You can dissect this septum muscle long enough until we complete the click-pharyngeal myotomy. So left behind, you can see mediastinum. And behind the bottom of the mediastinum, you can see a surface of the lung. Anyway, after completion of the myotomy, for in this case a 3 centimeter myotomy, we just close the mucosal entry using clips. So like this way, after at Z point, there is no deposit of the contrast media to the divertigram. So next, I would like to talk about the another application of the poem procedure. Yes, that is a D poem, divertigram poem. So this is a case of our case on the bottom swallow. You can see very tight junction, the outflow obstruction, and also you can see a large divertigram, relatively large divertigram epiphrenic area. So endoscopically, we can see the so center image. You can see esophagogastric junction, right side, and the left side, big opening of the diverticum. This is a manometry demonstrate the relatively high pressure in the outflow of the esophagogastric junction, but normal pressure. Yes, this is the 5 centimeter proximal from the diverticum orifice, the same direction of the diverticum, right edge. So we are trying to approach from a 7 o'clock direction. So after injection, we are trying to cut the mucosa. Now we are in a submucosal space, trying to create a submucosal tunnel. So submucosal tissue was dissected along the surface of the muscle layer. So now using the double scope technique, we identify the position, exact position of the submucosal endoscopy. Now you can see this is a limb, the entrance of the diverticum. Muscle defect edge, we can see it. So the first step is like this. After identification of the muscle defect in the submucosal layer, so our submucosal endoscopy goes into the mediastinum and then try to dissect the diverticum itself. So diverticum is a shoot diverticum. That means not a full layer, so just the mucosal layer we dissected. So this diverticum has no muscle layer. So you can see our mucosal layer is going into the going inside the diverticum itself. So you can see it. Some connective tissue remains. So we are trying to dissect it. So in this case, we are intending to dissect the diverticum itself, because this case the diverticum itself has some volume. So we think it's better to dissect it. In this case, we are trying to give traction to the diverticum mucosa, inverted to the esophageal lumen, and then try to dissect the connection to the attachment to the pleura. Yes, this is a connective tissue attaching to the pleura. In this case, after total mobilization of the diverticum itself, so we try to clothe the defect of the muscle layer using the suturing device. So like this way. So you can see a muscle layer edge, and we are trying to catch the right limb. Then one stitch, and then approach to the other side. So while we are using the V-lock, so this is a left limb catch by the suturing needle. Okay, then so we pull the V-lock. So this suture material is very convenient. Just pull it up, then we can make a tight approximation. Like this way. We can close the muscle defect using suture. After this, diverticulum itself are inverted into the esophageal regional lumen, but so this mucosal component is too large, and then potentially occlude the GI lumen, esophageal lumen. Then we decided to cut it using the snare, like this way. We have already placing the loop closure, and then after that we cut the part of the mucosal of the diverticulum. After that, we can get the tissue position well. We applied several clips to make a complete closure of the cut end. Anyway, so this is the after endoscopic view after closure. On the right side is the beautiful resected specimen image. So like this way, so before procedure, you can see a big diverticulum, but after this procedure, no leakage, and the diverticulum itself is gone. And the 6 days after procedure, swelling can pass very smoothly the outflow of the esophagus. So, of course, we in this case completed LES myectomy. So, lastly, I would like to talk about the post-POEM GERD, how to avoid it. So, POEM itself a good procedure, effective procedure for esophageal achalasia, but potential risk of post-POEM GERD. So, symptomatic GERD is 20%. So, pH abnormality is 50%. And the severe GERD is not so much, 0.1 to 3%, depend on the reporters. So how to avoid the post-POEM GERD? One technique is a double scope method to control the gastric myectomy length less than 2 centimeters. But, so once the patient becomes a severe reflux disease after POEM procedure, then we can do the endoscopic door fundoplication. We call endoscopic fundoplication. So, this is the hair door surgery after placing the myectomy. In order to avoid the potential reflux disease, we add the anti-reflux partial fundoplication in a surgical procedure. So we do this procedure using the flexible endoscope. So first case was done in 2017. So far in the hospital, we did 45 cases of a POEF. And we have already reported, so this is one of my colleagues, Dr. Akiko Toshimori sensei, so she reported. After getting into the abdominal cavity, so we keep the retroflex view and then approach to level of the fundus, anterior wall of the gastric stomach. And then actually we place the needle suture onto the gastric wall. And then we also place the proximal suture to the esophagogastric junction. Normally we place 2 stitches, and sometimes place 3rd stitches as well. So in this procedure, we use the endoscopic hand suturing device developed by Dr. Goto. This is the submucosal endoscopic view in a submucosal tunnel, anterior wall of the esophagus. Now we are dissecting the peritoneum and try to open the entrance to the peritoneal cavity. Behind, you can see the back side of the left liver lobe. So now we are dissecting the peritoneum, and then I try to open it widely, and then getting abdominal cavity, the CO2 insufflation. We are placing the suture, transmural suture, this way. So needle is coming back and then out. Okay. So at this moment we control the gastric gas using the second scope. You can see our needle that passing to the intragastric lumen, and then the needle is out. So now we are pressing the proximal anchor, placing the suture onto the right crus of the diaphragm in a submucosal tunnel. Then just pull the V-lock. We can create the lapping fundiplication like this. This endoscopy image is very similar to after door fundiplication. So this is a clinical result. Feasibility is a technically success rate is 100%. And the pH impedance study demonstrates the compared to polymer alone group, with the fundiplication group have a better results of pH study. So this is a schematic drawing of the anti-reflux procedures. Nissen fundiplication is the most strong, and then the toupee is the next, and the dole. So POEF is a very mild anti-reflux procedure. So this is the last slide. POEM opens the door of submucosal endoscopy. So now we apply this technique to our several GI tract disease. Thank you very much for your kind attention.